Pleasure to announce this conference, declare this conference open. Thank you very much.
Now the first speaker of today is Dr. Jyoti GS.
Good morning one and all. I begin my talk, anatomical and physiological changes in pregnancy from a critical care point of view. We all know that physiological changes occur in pregnancy to nurture the developing fetus and to prepare the mother for pregnancy and delivery. Some of these changes influence the normal biochemical values and others may mimic symptoms of clinical diseases. We need to recognize the pathological deviations in these normal anatomical and physiological changes so as to institute appropriate treatment for better outcome. And we also are seeing that the obstetric population has changed over the past decades, and we are getting a lot of elderly gravidas with existing disorders, advanced chronic medical conditions, and the intensivists should also be aware that deaths due to these conditions are exacerbated by pregnancy due to indirect causes. The indirect causes are on the rise. Therefore, obstetric patients admitted to an ICU present challenge to an intensivist because of normal physiological changes associated with pregnancy and puerperium. So what are the reasons for ICU admissions? It could be conditions related to pregnancy such as eclampsia, severe preeclampsia, hemorrhage, amniotic fluid embolism, AFLP, etc. Medical diseases that could be aggravated by pregnancy such as congenital heart disease, rheumatic, non-rheumatic, pulmonary hypertension, anemia, etc. And conditions that are not related to pregnancy like trauma, asthma, diabetes, autoimmune diseases, etc. So we should remember that when we are treating a critically ill obstetric patient, in general, what benefits the mother is good for the fetus. And also, in the obstetric patient, uterine displacement should be considered part of the ABC, or rather we can say CAB evaluation in the hemodynamically unstable obstetric patient. So let us come to the different systems. The hematological parameters, we can see that the total blood volume starts rising initially by 45%. This is due to the rise in the plasma volume and the RBC volume. The plasma volume raises by 10 to 15% early and 50% by the third trimester. The red cell volume falls early, then rises by 30%, but not as much as the plasma volume, resulting in the hemodilution of pregnancy. And another thing is the clotting factors 5, 7, 8, 9, and 12, along with fibrinogen, increases, and the prothrombin 3 and the factor 11, protein C, S, plasminogen activation inhibitors all decreases. So this leads to a hypercoagulable state in pregnancy. So there is hemodilution and hypercoagulable state, and so this predisposes to venous thromboembolism, most common in the left leg or the left iliac system. This is due to the kinking of the left iliac vein by the right iliac artery, where there is turbulent flow in the right iliac artery, especially in the late pregnancy or early puerperium, and it is exacerbated when the patient does not ambulate well. This increase in the blood volume and the coagulation factors will provide physiological protection against hemorrhage. So for example, a pregnancy, we know, I've been telling, it potentiates hypercoagulability, and when a patient comes with leg swelling, dyspnea, and tachycardia, it could be due to pulmonary thromboembolism also. We may think it as a physiological change, but there is sudden onset of dyspnea in pulmonary thromboembolism, and diagnostic confirmation can be done by the specific test of PTE. And you can start anticoagulation with low molecular weight heparin, and thrombolysis is reserved for cases with shock and life-threatening cardiorespiratory compromise. You see this chart. What strikes us it when the blood loss is more than 2000 ml, then when 1/3 of the blood loss occurs, then only we can see the abnormal clinical findings. So till then we cannot see the abnormal clinical findings because of the hemodilution of pregnancy. So we may underestimate the blood loss and delay taking active steps to prevent further bleeding. However, it has been seen that delay in the correction of hypovolemia and impaired coagulation are the avoidable factors of maternal mortality caused by hemorrhage. So we have to load the patient with fluids, give oxytocin, and if necessary, only in certain cases, factor 7A is recommended. In a patient with septic shock, the earliest indication is vasodilatation and tachycardia. The same is seen as physiological changes and is masked due to physiological changes. So you should look out for surrogate markers for global hypoperfusions. And fluid challenge is also, we should admit very judiciously, because pulmonary edema can occur in septic abortion because the colloidal oncotic pressure is lower than 14% than the normal, and always maintain lateral tilt to reduce supine hypotension. So the vasopressor agents may have deleterious effect on the uteroplacental perfusion. We should remember the very phenylephrine and ephedrine are supposed to be a little safer. Assessment of the uteroplacental fetal unit is an important guide for adequacy of tissue perfusion and resuscitation. Coming to the cardiac output, the heart rate, the stroke volume, and the cardiac output all rises by 30, and 50% by third trimester. The systolic blood pressure falls, but not as much as the diastolic blood pressure. It falls by 20 to 25%, and in the initial stages and later comes to the non-pregnant level. This is because of reduced peripheral resistance, because placenta acts as an AV shunt together with the other peripheral vasodilating factors like estrogen, progesterone, increased endothelial synthesis of prostaglandin E2 and prostacyclins. So when the gravid uterus is pressing over the inferior vena cava, causing supine hypertension, when there is cardiac arrest, in order to minimize the effects of gravid uterus on the reduction of venous return and cardiac output, a pelvic tilt to the left of greater than 50 and less than 30 is recommended. Because of increased heart rate and stroke volume and cardiac output, women with heart disease and fixed cardiac output may not cope with the demands and may develop pulmonary edema. Both blood pressure and cardiac output fall during epidural analgesia. In as much as 8% of cases, there could be 30 to 40% fall in the blood pressure. The pregnancy state is such that it is a it's a pro-arrhythmic state, and paroxysmal supraventricular tachycardia is more common, and treatment of cardiac dysrhythmia in pregnant women is similar to the non-pregnant patient. However, amiodarone should be avoided as it inhibits fetal thyroid function. The pearl is the patient in a last month of pregnancy may display some of the clinical features akin to congestive cardiac failure as a result of physiological adaptation to pregnancy. Although there is a small risk of inducing fetal arrhythmias, cardioversion and defibrillation are considered safe at all stages of pregnancy. Coming to the respiratory system, if there is increase in the neat ventilation by 40% due to increase in the tidal volume by 45%, this is because there is reduction in the functional residual capacity as a result of decrease in the residual volume by 15% and the expiratory reserve volume by 25%, because the diaphragm pushes the lungs upwards by 4 centimeters and the circumference increases by 5 to 7 centimeters as early as the early trimester when the uterus is still at a lower level, and the oxygen consumption is also increased by as much as 30 to 50%, and so due to the pressure on the diaphragm and the lungs, there is increase in the resting oxygen demand, resulting in faster onset of hypoxemia. Dyspnea is a presenting symptom in 50 to 75% cases. There is hyperventilation, fall in the PCO2 and PO2, and because of laryngitis, rhinitis, because of capillary congestion, there is increased risk of bleeding, rhinitis, laryngeal edema, hypertrophy of the breast, estrogen, which is estrogen induced. There could be difficulty in intubation. So we should protect the airway. They are more prone to develop regurgitation and aspiration, and intubate if necessary. If it is difficult to intubate, LMA should be kept in mind. Okay, and if you are not able to intubate, administer oxygen, as they are more prone to rapid acute oxygen desaturation. Coming to the nervous system, altered anatomy and responses to pain and pharmacotherapy occurs as pregnancy progresses. There is increase in the venous pressure below the gravid uterus, causing the blood to be diverted towards the spinal vessels, and epidural plexus gets engorged. There is a decrease in the CSF volume and diminished epidural space and increased cerebral flow. So space reduction with enhanced neural susceptibility leads to local anesthetic reduction. You have to reduce the dose to 25% whenever you're giving spinal and epidural anesthesia. All sedatives and anxiolytics and analgesics used in critical care are safe both for the mother and the fetus. Coming to the renal system, the GFR, the creatinine clearance increase initially by 50 and 40% and declines gradually. There's glycosidia, proteinuria, and the retroverted gravid uterus presses on the urethrovesical junction, causing acute retention of urine in early pregnancy. Because of dextrorotation of the uterus, there's pressure from the gravid uterus causing dilatation of the ureter, increased risk of pyelonephritis, and difficulty in interpretation of radiological studies of the urinary collecting system, and treatment of asymptomatic bacteriuria reduces the incidence of pyelonephritis. So when we get a case of preeclampsia and eclampsia, they have narrowed upper airways secondary to soft tissue swellings, neck, facial and tongue edema causes difficulty in airway, thrombocytopenia can occur that causes more problem shifting from local to general anesthesia. Fluid challenge in the setting of oliguria in these patients may produce pulmonary edema, and oncotic pressure may reduce post-delivery, and phase of diuresis occurs with 24 to 48 hours after delivery. This we should keep in mind. So the pulse of the serum creatinine level tends to remain below the normal non-pregnant level unless there is severe preeclampsia with associated renal failure, and hypertension in obstetric patients must be considered as a sign of preeclampsia unless otherwise proved. Coming to the gastrointestinal system, there is reduced lower esophageal sphincter pressure, high intragastric pressure, delayed gastric emptying, reflex esophagitis, heartburn, constipation because of reduced motility of the lungs, high risk of aspiration. 49% of the women undergoing LSCS are at increased risk of aspiration. Decreased colonic mobility will alter the antibiotic absorption and delay the gastric emptying. Accumulation of higher doses can occur. The liver function tests usually are normal. There could be some amount of cholestasis in the late trimester. Endocrine system, physiological changes, there's increase in anti-insulin hormone, HPL, glucagon, cortisol, and therefore the glucose tolerance decreases, increased insulin requirement, and exacerbation of complications of diabetes such as nephropathy and retinopathy, and it can significantly affect the pre-existing diabetes. There is increased insulin excretion, so they may need increased insulin dosage. Skin, there is hyperpigmentation, spider nevi, and palmar edema are normally seen in pregnancy. Hyperthyroidism, there is transient hyperthyroidism due to action of HCG on the TSH receptor due to identical subunits, and there is also increase in the thyroxine binding globulin. So increase in TSH, you should not take it so in the first trimester. You should even think of free T3 and free T4 levels should be considered. Most cases of true hyperthyroidism in pregnancy are due to Graves' disease, which complicates about 1 in 500 and pregnancies. Choice of antibiotics depends on the safety of the growing fetus and penetration of the placenta. Volume distribution of the drug increases due to increase in the total body water, decrease in the serum albumin, so that I told you some drugs bind to the albumin, decrease. So free form is more, delayed gut motility and gastric emptying also increase the drug absorption, increase in the renal blood flow and GFR also increases the excretion of water soluble drugs. These are all things which you should keep in mind. 1 minute. And so I conclude to say that optimal management of the critically ill obstetric patient necessitates a multidisciplinary approach with close collaboration of the critical care team with the obstetricians, midwives, anesthesiologists, and neonatologists, a thorough understanding of disease, particularly to pregnancy, and more importantly, maternal and fetal physiological adaptations that occur will help guide the initial resuscitation efforts as well as the ongoing critical care management. So admission of pregnant women to an ICU is considered as an objective marker of severe maternal mortality. Thank you one and all for your patient hearing my references. Thank you.